So we are at our surgery center, state-of-the-art facility that we built specifically to do lots of total joints. We have hired our anesthesiologists and surgical technicians and athletic trainers who are all trained and geared for total joint replacement surgery. We're able to do high volumes of total joint replacement outpatient. Patient comes in the morning, they get a spinal anesthesia, they get up and ambulated after surgery, and they get to go home the same day. This is a 68-year-old female. She had bilateral hip pain, meaning both hips were hurting her right worse than her left. It's been hurting since 2021, got worse in August of 23. It's now limiting her ability to do simple activities, doing stairs, household chores like vacuuming, walking her dog, which she loves. She can't do that anymore. She has maximized all other therapies. So she got some anti-inflammatory medication. She was taking pain medication like Tylenol. She got some therapy, and nothing was helping. So after several years of this non-operative therapy, she's now indicated for total hip replacement surgery. Her x-rays are classic. She has bone-on-bone arthritis. There's no joint space. There's these cysts or holes both in the femoral head and on the cup side, the acetabular side. She has sclerosis. These are all signs and symptoms that are specific for hip arthritis, and her exam, when you try to rotate her hip, she's miserable. So for all those reasons, we're gonna go give her a brand new hip. Made a skin incision, dissecting down through the tissues. We decided to do a posterior approach on this particular patient. Post approach remains the gold standard in the United States. The decision to do it from an anterior approach or posterior approach is completely up to the surgeon, and there are benefits to both, but we have to remember that hip replacement surgery in general has a 98% success rate. So no matter how you choose to do it, the patient has an incredibly high chance to have a great result. Obviously, the first thing you need to do in a hip replacement is dislocate the hip, pop the hip out of place so that you can replace it by flexing, adducting, and internally rotating. And the hip is now out of socket. I take a saw and I cut the femoral neck to remove the very diseased femoral head. The very diseased femoral head, consistent with the x-rays, no cartilage at all left. Big holes are the cysts that we see on x-ray, a very diseased femoral head. At this point, I'm going to expose the cup. So the hip is a ball and a socket joint. This is the socket. And that is a very, very unhappy hip joint. So now we're going to take a reamer. This is a reamer. It slowly removes all of the diseased cartilage that's left in there, because that's what we want. We want nice, healthy, bleeding cancellous bone. One more. We will progressively increase our reamers until the appropriate size has been achieved. I'm reaming in the appropriate inclination as well as version. These are the components, these are the positions that you put the component so that the patient has excellent range of motion and doesn't pop out of place. The implant itself is actually slightly bigger than a 50, like a 50.2. And that's so we can get what's called a scratch fit or a press fit. So on the back of it is actually, this is a 3D printed cup. It is not a coating, it's actually metal. And the initial fixation will be that press fit technique where you prepare the bone a little bit smaller than what you put in. But ultimately, the long-term fixation will be biologic fixation, where the bone grows into and onto this metal. This metal has pits and valleys in it that mimics our bone, and that will be the ultimate fixation. I gently impact my cup. I have excellent fixation. I'm going to put a practice piece, if you will. It's called a trial. So ultimately, this will be a highly cross-linked piece of plastic. Right now, it's just a practice piece to make sure that I like all the pieces before I commit to using the final product. At this point, we're now going to address our attention away from the cup, and we're going to do work on the head. Again, The hip is a ball and a socket. I've already replaced the socket. Now I'm going to replace the ball. Earlier in the case, I cut off the old femoral ball. It was very diseased. And the new ball will be made out of metal in this particular case. Sometimes we use ceramic. It just depends on the patient's pathology and age. Similar on the cup side, we're going to take different broaches, which are going to remove some of the bone as it goes down the canal, some of the inside of the bone, and I'm going to continue to increase them in size and width, and listen and feel when the right size is appropriate. My assistant's going to relocate the hip now, very gently, very nicely. And then I'm going to move the hip around to test the stability of the hip. I'm checking my combined version. This is where the cup is sitting perfectly concentric. Where the ball is sitting perfectly concentric within the head. Now I know my assistant set the patient up exactly perpendicular to the floor, so this angle here, the angle between the floor, if you will, and her leg, is going to tell me my combined version. That's the version of the femur and where I put the cup. And that's about 45 degrees, which is exactly what I would like for a female. 45 to 55 degrees, somewhere in there. 40 to 50 is the general accepted ratios, or accepted numbers and angles. I'm going to try to get the hip out of socket. It is not going to come out the front. Sorry, it's not going to come out the back. And now I'll try to put it out the front, and that's not going to happen either. So it's a very nice, stable hip replacement, and that's what I want to use. So now I'm going to remove the trial components. So this is the piece of plastic that I'm putting in, highly caustic polyethylene. This is the real liner. We took out the practice one, if you will, the trial. And I put it into the cup that I've already previously placed in there, and I impact it into place. Cob. I ensure that it's nicely secured into the locking mechanism, which it is. We're totally done with the cup side. Now we'll work one more time on the femur side. I liked what I had in there, and so I'm going to put the real deal in there. This is the real stem, where this one is coated. It is not a 3D model. So the top of it is coated, and the end of it is actually sprayed, plasma sprayed. And all of that is so that we can get definitive biologic fixation where the bone grows into and onto the bone. We're always thinking as a surgeon of the next potential surgery. So I'm doing a final cleaning of the piece that I put down the femoral shaft, and now I'm taking a metal ball and I'm putting it on the top of that femoral prosthesis or component, and I am impacting it into place with a nice tune. Make sure it's there, and my assistant will reduce the hip one final time. And there we now have a completed total hip replacement. The hip is moving nicely. She'll have very little discomfort. About 45 minutes from now, she'll be up and walking, hopefully smiling, and doing great. And then she'll go home shortly thereafterwards. So we encourage these patients to attend some physical therapy sessions. Not every patient needs physical therapy. We here at Orthopedic Medical Group offer 3 different locations for physical therapy to help the patient get stronger, learn how to walk again. In some instances, this poor lady hasn't walked without a limp in years, so she has to learn how to walk again to a certain degree. Therapy can help do that. But in general, the hips don't need extensive long-term therapy. They're back doing their activities and enjoying life very quickly.